I'd like to invite Dr. Lam Ho to give us the next talk, Calcified In-Stent-Restenosis PCI, How to Overcome Challenges.
Good afternoon, everyone. I just try to talk a case. It's not planned for a topic, but just share this case, what we have done. This is unusual and unusual and not a standard case. The patient had MI and DM and hyperlipidemia, hypertension before, and the patient had PCI before, and echo so EF around 45%. The patient had recent angina, and then that's why he go for CT angiogram and found the patient has significant disease. This was the angiogram of the patient. You can see very clearly the AD is CTO, and you may not be able to see the stent clearly over the angiogram, but there's a stent over the mid-AD. Yes. The CTO start from very proximal AD. Although the RSA has significant lesion and anomaly and loss of calcium, but there's retrograde supply to the AD, so it's okay. From this view, you can see that the AD are heavily calcified with some stent. Yeah, so we try to do PCI on this case. Standard procedure, contralateral injection, and then wire. It's very difficult to wire this case. Finally, we need to step up to Gynex 3, and finally we can wire it, but we cannot pass microcatheter. In this case, we try to just tip in past the microcatheter to the end, the maximum we can go, and then change to workhorse. And then we try to use laser to treat this calcified ISL lesion and see what is the outcome of that. Anyone had experience on laser for calcified ISL? It's just a legend. It's also my first experience, and I hear many of talk, but from many Taiwan doctor or other fans, they told me it's not effective, it's not work, and it's not good. But anyway, I want to try to see what is the outcome. I workhorse and then used 0.9 mm laser because it cannot cost. I don't expect I can cost with a big laser, but a small one, and then use highest pressure, use blood as medium. I check the energy level, everything. If you do this with maximum energy, with blood, and in fact, the difference between using blood and contrast is minimal. So with this is already very good. So we try this laser, and then finally our laser can cause after a long attempt, multiple attempt, long attempt. Finally, the laser can cause, and then we slightly dilate it, and then after that we do OCT. Repeat the angiogram is like that after the laser, and then repeat with OCT, and try the best to see the efficacy of laser on calcified ISL. Yeah, this is the best OCT quality. Can you replay the OCT? Yeah. Can you replay the video? But no worry, I prepare the still image. You can see the calcium are heavily calcified. For the laser, the major effect is it burn the fibrotic tissue. Many of the time in those calcified ISL is the calcium, and then on top we have some fibrous tissue. I found that with laser you can burn the fibrous tissue, but you see from the OCT, despite we use maximum energy, multiple attempts, there's no crack on the calcium. Nothing had happened on the calcium, but fibrous thing will go away. This will help to reduce the risk of trap burr. In my experience, I can feel that the major effect of laser is burn the fibrotic tissue, reduce the risk of trap burr. And then we start with 1.5 rotablation, very hard to cause.
Do you use laser or not? No.
And then this is the angiogram after the rotablation. So bigger size burr, because you can see the calcium is very thick. I try a 1.75 burr. And after that, we do the OCT again to assess how many calcium we can remove. We can find that we can remove a little bit more, but inside here, inside, I mean the calcified eye cell, despite you upgrade a little bit, we already tried the best use 1.75 per differential speed, but still loss of calcium on the surface of the stent. And then in this scenario, we use OCT. Of course, we can co-registrate. We can know where is the calcium eye cell, calcified eye cell, where is not. So we stent just the distal and the proximal. In the calcified eye cell part, never stent. Trust me, we had other case, other experience. If the eye cell is calcified, you cannot completely remove. You put one more stent, and they will just like building a concrete building, a tall building. You have the steel inside and then give some concrete, and then you will be very strong. You can never open it again. So we plan to use DES for proximal distal, calcified part just plan for DCB. We try to predilate everything after the stenting. Middle part touch nothing, but you can see from here. The mouse cannot show, but you can see from here it's not dilatable. Yeah, it's not dilatable. The other part dilatable, this part is not dilatable. And then, yeah. This is the angiogram after the stent, the distal, stent the proximal, but the middle part we did not stent because heavily calcified and it's not dilatable. So I really cannot think about any strategy to deal with this. I tried the last resources to use a short wave. But it should be supposed it should not work because it just crack inside. Suppose it do not work. But for this case, you see the short wave is not expandable, but after few shot, it's expandable. I guess the mechanism is after different rotablation, it make the calcium on top of the stent become more loose, and then together with the short wave, some of this calcium can dislodge. And after that, with NC and then DCB, yeah, sequence paste DCB. Never put stent on top of a calcified eye cell, it won't work. And this was the final angiogram and final OCT. I can just say this is a atypical and unusual case. Most of the time, if it's calcified eye cell, even after the short wave, it cannot help you to remove something inside. If you really want to try this strategy, through the experience on this case, I will feel that you still need rotablation first, and then short wave. That may be the last attempt. So this was the final angiogram. Okay. Final angiogram. Okay. Okay. So the major thing is to, through this case, demonstrate to you the effect of laser, Volta, IVL on calcified eye cell. Okay, thank you.
So we let the discussion to the end of the session, but I just want to ask any of you in this room have laser in your cath labs? So Sujo, Frankie, Ramesh, Eric, yes, quite a lot. Yes, I think here Vietnam we don't have laser. Malaysia is no laser.